and looking at different ultrasonographers, and then looking at dogs that went to surgery and what was found at the time of surgery. And there was a statistic of 60% of the time, something was found at the time of surgery that was not found at the time of ultrasound. So ultrasound in the liver even can be an excellent diagnostic tool, but we always have to remember sometimes there's some things occurring there that we just can't see. So the liver nodules were seen and biopsied. So then his histopath came back pretty good. So at least now we don't have to worry about spleen cancer because it's out of him. So lymphoid nodular hyperplasia, which is what we had before on his cytology. And then his liver was nodular regeneration, and his intestine and stomach and biopsies were all normal. So I rechecked him. So 2 weeks after surgery, he had a recheck, and his energy level was better. He was feeling better. He was playing more. He was still picky, though, with eating, the owners reported, and they were adding some broth to his food to get him to eat. And he had 2 episodes of retching. He didn't bring anything up, but just retching. So I did a CBC. So now he's anemic again, worse than before. Hematocrit is 26%. His white blood cells are abnormal. He has a lymphocytosis. He has an eosinophilia. And so I thought, I was getting afraid that he had something in his bone marrow that we were going to find that was going to be a serious problem. So that exam, because of the eating, the owner wanted me to really look thoroughly in his mouth. So I had inspected his mouth previously, but I looked really well, and it appeared that his maxillary left fourth premolar was infected, and he chattered when I went along his gum line and pushed on it. So I wanted to empirically deworm him as well during this appointment, so we got that going, and then I reviewed his history. So I just wanted to kind of sit. There's a reason why I did the panicure is because I sat down and I was like, at some point he got better. His hematochezia got better, his blood work got better, things got better. So what happened to lead to that point? And I discovered that besides all the GI protectants and medication he had received, he had also received panicure, but it had only been given for a short period of time. He never had gone through the typical treatment plan. I tend to be very aggressive with panicure. I do 7 days, and then I repeat it 2 weeks later. And then if I really think that it was something that was effective, I repeat it 3 months later. And he'd only had a few days of it. And so I thought that it would be worth doing the panicure again. And because of the anemia and the hypoalbuminemia, I kept trying to connect this to something more in his intestine, and maybe something that we just didn't find on the intestine biopsies. So I theorized, could he have a hookworm infection? I did discover he had received ProHeart within 6 months, and that is labeled for hookworm, but I still thought, well, it'd be worth deworming just in case. So now we have a tooth infection, and he's being dewormed. So he comes back to recheck with me a couple weeks apart here, end of August, early September, doing much better, eating well. It was a very positive report. He has a reticulocyte count over 150,000, a very regenerative anemia, but he's still anemic, but he's getting better, so I felt, okay, treatment's working. Neutrophil count was pretty normal. Lymphocytes are still elevated. At this point, I've just decided this dog's gonna have a high lymphocyte count, so I put him on clindamycin for the tooth infection, and we did plan to have a dental, and then he went back on his second course of panicure. So he came back then the end of September, and he was doing well, but now on his blood work, his anemia is worse again. It's a mild microcytic non-regenerative anemia at this point. So he went from a regenerative anemia now to non-regenerative anemia, a lymphocytosis of 7,400 and an eosinophilia of 1,900. So I did a cobalamin and folate level on him. Both came back normal, and then I decided to do iron testing. Iron deficiency can be regenerative at some point, and it can be non-regenerative, so it can present both ways. So I felt, well, let's check that and see what that shows, and that all came back normal. I send, if I do iron testing, I send it to Kansas State, and he got total iron body concentration, iron level, and ferritin, all normal. So he did have his dental. We just went ahead and got that accomplished. He actually had to have 4 extractions, and that one premolar was extracted. He did well after his dental. He was gaining weight, he was eating, he was recovering. His red blood cells actually improved. His Paxil volume came back up to 34%. He took that 3-month Panicure treatment, and then the owner brought him in because they were concerned about a growth on his left front paw. And so he actually had that removed. He went underneath anesthesia for that, and it was a vascular hamartoma, so just like a bundle of blood vessels, so benign. So I planned to see him 3 months after that, and so I saw him for his recheck, and the owners reported he was eating grass, and then he was also having intermittent hyporexia, and it would just be like, his owners are very, very nice, and they would be in the room, and then you could just tell, she'd shake her head, and, well, there's just something that's not right with him. It's just, you know, there's something still going on. I'm just like, what is happening? So his Paxil volume at this check was 35%. So I sit down with his chart, and I review everything, and I'm like, what have we not tested him for? Which I think everybody knows. It's a big surprise. So he needed an ACTH stimulation test. He just threw too many things out there all at once, so it was time to do a stimulation test. So I sent his stimulation test to Michigan State. I use IDEX as a reference laboratory, and I do most of my stimulation tests through IDEX, but I felt that he was not an emergency, and Michigan State is a little less expensive, and these people have quite a big investment at this point, so I was trying to figure out how I could help them as much as possible, so I just sent it to Michigan State, and he was flatline, 0. 0 on pre, 0 on post. So the good 1-hour ACTH stimulation test that we use to diagnose all Addisons with, and in this case, what he would be called atypical, because he does not have electrolyte abnormalities. This whole time, his sodium potassium remained normal. So here's Mac's evidence of atypical Addison's disease. He was having hyporexia. He was showing evidence of nausea with the grass eating. He had decreased energy. Seizures can occur with Addison, so lack of cortisol can cause seizures. He had lymphocytosis. He was lacking a stress response most of the time. He had an eosinophilia. He had anemia, and at one point it got to be regenerative, but it was usually non-regenerative. He had low cholesterol. He had low albumin. And then on ultrasound, his right adrenal gland was smaller than you would expect for the size of him, and his left adrenal gland was not seen. So treatment for atypical Addison's disease is, it's the same as what we would treat typical Addison's disease with. It's going to be a physiological dose of prednisone or prednisolone, 0.25 mg per kg per day, and typically lifelong. Some of these animals can be treated with a lesser dose of the prednisone. And then some of these dogs do need a higher dose. So for Mac, I didn't give him a higher dose because he had endured something like 4 anesthesias, 1 sedation, and that long period of time without having any problems, so I just gave him a physiological dose. So the owner calls within like a week, and Mac has severe polyuria and polydipsia from his physiological dose of prednisone. And I'm like, what? You need this. So I lessened it, I halved it, and that is the dose that he gets. So he gets like a 0.12 mg per kg per day dose. And he feels like, he's just amazing. He's a completely new dog. They're just thrilled with how he's doing. I feel like we've kind of taken care of all Mac's problems that we can possibly take care of. I don't know what he's going to present in the future, but he's doing really, really well. So it was very rewarding to finally get him worked out. So how can atypical Addison's disease progress? So it can eventually, and like I mentioned, we had to review the RAS system. These dogs may truly have an aldosterone deficiency, we just don't measure it. So these dogs can develop abnormal electrolytes as time goes on. So it's usually best to monitor the electrolytes every 4 months. And there's been some evidence in the literature that if most dogs are going to progress to having hyperkalemia and hyponatremia, they're usually going to do so within the first year of diagnosis. And if they don't in the first year, it's unlikely they're going to in the future. But it still is possible. one could say, let's do an aldosterone level. Let's do the ACTH stimulation and measure the aldosterone level, which can be done through Michigan State. But say the aldosterone level is low and the electrolytes are normal. The recommendation is to not treat with mineralocorticoid at this point because they don't really need it, and the clients are then having to put extra cost into something they don't need. It's not probably going to be harmful, but then they still have to give the injection. So it's still that whole process. So the recommendation right now is to not provide mineralocorticoid to these dogs, even if you were to prove their aldosterone was low. Now that poodle I mentioned earlier that I've learned from, that dog gets a Percortin injection about every 6 months because it just makes everybody feel better because we do know the aldosterone level is low. The electrolytes are normal, but that makes the owner feel better. I'm willing to do it, so she doesn't want to do it at home, so we just give it in the hospital. So 1 out of 11 dogs in a study that was done in 2007 progressed to having mineralocorticoid deficiency over a period of 1 to 4.5 years. And then there's other studies that suggest that it's unlikely that they may never have a problem. I've monitored Mac. He's not developed an sodium-potassium problem. At this point, now that I've reviewed the 2017 study, it would be interesting to measure his aldosterone, but then I don't know what I'm going to do with the information I get. So this is just a list of breeds that are at increased risk for having good old Addison's disease. And it kind of depends on where you look as to what list you find, but Airedales, Bassets, Bearded Collies, Great Danes, Nova Scotia Duck-Tolling Retrievers, Portuguese Water Dogs, Rottweilers, St. Bernards, Springers, Standard Poodles, Westies, and the Wheaten Terriers. I have a Wheaten Terrier, and after I was working on this, I had just done blood work on her, and I went, what was her cholesterol, high or low? It was actually up a little bit, so I was like, okay. So then breeds at decreased risk for Addisons: Boxers, Chihuahuas, Cockers, Dalmatians, Goldens, Losses, Pit Bulls, Pomeranians, Shelties, Shih Tzus, and Yorkies. So I just wanted to bring everybody's attention to a website. This is where the client with the poodle taught me something. Has anyone heard of the website addisondogs.com? So it's just singular, Addison. Don't put an S after Addison. I did that once and the computer did something and shut down. So just leave out that, don't say Addison's, Addison dogs. And it is a website that looks pretty reputable. It's a source where you could have clients go to get information on Addison's disease in their dogs. And there is an interview done with Dr. Julie Bates. She's an internist. She is practicing at the University of Wisconsin, last I knew. But she did her residency at Michigan State. And so being a major endocrinology university, she was definitely well educated on it. And at Michigan State, they have a protocol, and she talks about it in this interview. And so now I'm talking about full-blown Addison's disease. So using Percortin, using prednisone. They don't treat their dogs with the FDA-labeled dose of Percortin. They train their residents to actually use a lesser dose. And also they are pretty conservative on their prednisone dosing. So like Mac, I just discovered through his symptoms, needed half the dose, and he's maintained well on half of that physiological dose. Where Dr. Bates was trained at Michigan State, they may have recommended already starting at half that physiological dose. So, and it kind of needs to be tailored to the patient, but they aren't using the full Percortin dosage that's on the label. Now, they do caution, like Dr. Bates in this interview cautions that if one's going to go off that label dose, you make sure your clients are aware as to why you're doing it and educate them so they understand that since it is off label. But this interview is interesting. She does talk a little bit in there about atypical Addisons, and it's that website, and then you have to click on, there's like another link about just more information, and then her interview is over on the right side. So my client that brought this little poodle to me, which is, things are going fine now, but this dog had to have a lot of changes in its prednisone. It takes a very tiny amount. It had to be compounded. We had to switch to prednisolone at one point. It has to be a liquid. But she was ready to go there to see Dr. Bates in Wisconsin. We got it all sorted out now, but she was just so frustrated with trying to help her dog, and it just wasn't responding like a typical dog. But that's just a different case than the case I just presented. So I did want to mention here before I finish that I have gotten involved in some clinical trials, which has been a very good experience. It just kind of came to be a couple of years ago through a company called Atypical, and they are a monitoring company of clinical trials in the United States, mainly in veterinary medicine. And I didn't know what Atypical was, so I did a little research. I learned that our cardiologist, Dr. Leffers, had done a research trial with them when she practiced in Texas, so it was a very positive report. And then I also ended up sitting by a veterinarian that was a nutritionist at a conference, and she had actually worked with Atypical. And this was all kind of finding out these connections right around the time that we learned about this acute pancreatitis trial. So I was involved in an acute pancreatitis trial. It started in the spring of 2017. We did do the first trial, and then there was a second part that was just very short. It started this past November, and it just finished. As far as I can say right now, the acute pancreatitis trial is completely finished. We had 10 patients total, and it is investigating a new drug that is actually already approved for use in Japan. So it is a drug that's out there, and it can be used in pets and dogs that have acute pancreatitis in Japan. But the drug is designed to try to prevent the neutrophil migration into the pancreas. So it may someday be something that we will be able to use in the United States. So through that, I had some connections with the Atypical company, and they brought to my attention another study that they're getting ready to start. And it's on feline chronic renal disease and developing erythropoietin that's designed specifically for cats. So that way we're not running into the antibody production that can happen with the human epigen or the human darbepoietin. So something that's specific for cats. And this is not going to be a placebo-controlled trial. This is going to be the actual erythropoietin being given to the cats. So we're actually going to go through training for that in a week. The Atypical company will come here, and they will explain the whole process of this. So I don't know all the details right now, but if you had a chronic renal failure patient that was developing non-regenerative anemia that needs something like erythropoietin, potentially your pet might be a candidate for this trial. So there will be literature being sent to referring veterinary hospitals and clinics that Atypical will be helping with, and you can always call me too with questions. And if anybody, we're going to send this to you, so I do have my references in there for some of those papers. And you never know where atypical Addisons, or maybe full-blown Addisons, because we don't know for sure, might be hiding. Are there any questions? Yes?
The megaesophagus that comes on, does that resolve that, or is that a permanent?
It's rare to have megaesophagus, but it can resolve. So it can. So once you get their cortisol levels up, you can see resolution of it. It may not though, because the esophagus can be, it's kind of like with myasthenia gravis. You hope it's going to resolve, but there's still that little chance it might not. Anybody else have any questions? Well, thank you.
Thank you for coming. Thank you, Dr. Totten. And again, if anybody would like a tour, I'm happy to do that.
Just talk to somebody at IDEX. They say, congratulations, you got one. Yeah, I didn't, because of you. But and we just spoke about it. We just laid on a credit. Okay, they were handed. client had it taxidermied afterward. It was like $4,000 or whatever.
I treat every one of my Addison patients with and it's nice, they don't have to come in with shots, and we have a compound for them, and it's a lot more affordable that way. Because the point one,
I don't find it.
what?
I don't find it.
Oh, Addison's? Yeah, only one time, they don't have that many going. We probably had 8 or 10 going in one time.
There you go.
This was crazy. Yeah, crazy.
Why they probably see me on CD. Well,
It's way around.
yeah.
So you're looking at building too big for them? You're looking at building too big for them? Oh, okay. But just that, they're yeah, but that's the sort of thing that they just are going to come here and stay in a hotel, work from dusk to dawn to dusk. That was, they remodeled the Army across the street, and they just tore it down to the shell. The Army's restaurant across the street. And they said, yeah, we've got just the exterior wall standing, that's it. We've got 3 weeks to get it done. And they were, it was just ants climbing all over the place. Yeah, it's a science. I mean, as opposed to local crews where it's just so much.
I'm glad that we're able to set up the space here to do this. Thank you. We're gonna